Welcome, everyone. Thank you so much for joining us. My name is Amna Hussein, and this is the first ever fireside chat brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. So the Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. So Kiara, do you actually want to go to our team slide? Perfect. So this is the Office of Community Outreach and Engagement. And so our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, treatment, survivorship, and clinical research opportunities. So again, my name is Amna Hussein. I am the Community Engagement Coordinator on our team. And on behalf of our team, I'm so thrilled to have all of you join us as we kick off our new virtual series. So as we quickly learned early on in the pandemic, patients with cancer represent a vulnerable population for COVID-19 due to immunosuppression, frequent exposure to healthcare facilities, and disruption of routine cancer care. Today, we will be hearing from physician scientist, Dr. Amit Kulkarni, and then Kiara, do you want to go to the next slide? All right, so Dr. Kulkarni is a medical oncologist specializing in thoracic malignancy, so that's cancers of the chest area. He is also an assistant professor of medicine in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota. Dr. Kulkarni joined the faculty in 2020 after completing his fellowship. His research is primarily focused on developing new biomarkers of immunotherapy response. He also has interest in precision oncology trials and early phase clinical trials. In 2020, Dr. Kulkarni was awarded a COVID-19 rapid response research grant from the University of Minnesota that helped fund a statewide cohort study that Dr. Kulkarni led that was aimed at defining the impact of the COVID-19 pandemic on patterns of cancer care and outcomes. This study was part of a larger multi-institution collaborative effort called COVID-19 Cancer Consortium. Dr. Kulkarni will discuss more of this study and the results during his presentation. So we will be recording today's session so that you can refer back to the recording on our YouTube page, and we'll send out that link in our follow-up email shortly after today's session. We edit every recording to ensure your privacy. And so before we get started, again, please take a moment to locate the mute and chat buttons. During today's presentation, please make sure that you are submitting all of your comments and questions in the chat box, or you can send them to me directly. And then following Dr. Kulkarni's presentation, we'll have plenty of time for discussion and a Q&A session. And so at that time, if you want to, you can unmute yourself. All right, so without further ado, I will pass it over to Dr. Amit Kulkarni to take it away.
Can you hear me?
Yes.
Thanks, Amna, and I thank the Office of the Community Outreach and Engagement for inviting me to talk in the inaugural fireside chat to talk about the impact of COVID-19 on patients with cancer. So let me share my screen here. All right. Can you see my screen now?
Yes, if you want to put it in presenter mode. Perfect.
Okay. So let me just turn off the subtitles here. Do you know how to turn off the subtitles?
Let me see.
Hello? Yeah, it looks like, yeah, I was able to do it.
Okay, looks like they're turned off. Perfect.
So So my name is Amit. I'm an assistant professor and faculty at the University of Minnesota. And I'm an oncologist by profession. So I see patients with cancer. Mostly I specialize in lung cancer. So I see a lot of patients in the clinic with lung cancer. So today I'm going to briefly talk about the impact of COVID-19 on patients with cancer. And this is pretty close to me because I've seen a number of patients with cancer and COVID-19. So this is a brief overview of my talk. We'll start with the introduction, and then we'll talk about the impact of COVID-19 in patients with cancer, data from CCC19, and then we'll talk about efficacy of vaccines and boosters in patients with cancer, and then talk about some other impacts of COVID-19 on cancer patients. I don't have any disclosures. So since the WHO declared COVID-19 by the SARS-CoV-2 virus a global pandemic in March 2020, we've had an enormous amount of loss of lives. This is the data as of December 7, 2021, last week. In the US, there are about a total of 50 million cases thus far. So one in six people in the US have been affected by COVID-19, and there have been about close to 800,000 deaths, COVID-19. The impact of COVID-19 in Minnesota is also very overwhelming and challenging. As of last week, we had about 1 million cases of COVID-19 since the pandemic started in Minnesota alone. And you can see on the right side how the hospitalizations are also reaching pretty close to its peak in December of 2020 right now. And overall, the number of deaths are again most recently rising. Thus far have been about 10,000 in Minnesota alone. Recently, there was a newspaper, a one-page article printed in the local newspaper, which basically showed, that how all the health systems are overwhelmed with COVID-19. And this is a newsletter signed by all of the CEOs of the major health system in the United States, urging people to get vaccinated and get their booster, wear a mask, and get tested if you feel sick. As Anna pointed out earlier, patients with cancer are highly vulnerable to adverse outcomes from COVID-19. And there are a number of reasons for these. Most of these patients are advanced age. They have a lot of medical comorbidities, meaning other medical conditions. They have frequent contact with healthcare. And obviously, they also have decreased immunity from the cancer itself or from its treatment. Also, patients with lower ECOG performance status, meaning patients who are weaker, are also the ones who have a much higher impact of COVID-19. We've known that hospitalization rates have been higher in these group of patients, with mortality ranging anywhere from 16 to 40%. Initially, when the pandemic started, the factors associated with increased risk of severe COVID-19 or death in patients with cancer were largely unknown. So we, at the time, needed a very rapid and real-time identification and reliable data in patients with cancer to systematically identify and validate factors that might increase the risk of severe cancer and COVID-19. So that's when the CCC19 consortium was born. This was started on a Twitter platform, and then it rapidly metamorphosized into a big consortium. This was led by Jeremy Warner at Vanderbilt University, and I was glad to be a part of this consortium, leading the effort from University of Minnesota. All of these oncologists on Twitter got together for one mission, And the goal of the CCC19 consortium was to collect and disseminate prospective and uniformly organized information on patients with cancer who are diagnosed with COVID-19 as rapidly as possible and at scale. So the CCC19 thus far has about 129 institutions throughout the country, as marked on this map here. University of Minnesota was one of the first 30 member institutions of this consortium. Currently, we have more than about 500 investigators in this consortium. So I'm going to present some data that is from this consortium. So the way we collected data was based on 4 different buckets. So the first bucket on the left side was patient demographics. What was the age, what was the smoking status, et cetera, and some of the other factors. The second bucket was COVID-19 initial illness. So what was the timing, what was the presenting symptoms, et cetera. The third was the details of cancer. So what was the cancer type, the stage, what treatments, et cetera. The last one, information that was on the right side, is basically follow-up. So how did these patients do over time? Were they in the ICU? Were they discharged? Were they on the outpatient? The primary endpoint of the study was looking at mortality at 30 days, meaning what patients died at 30 days following their diagnosis of COVID-19. So I'm presenting the results of the first about 5,000 patients with cancer and COVID-19. So these are the baseline characteristics of patients, and you can see on the left side that a majority of them are older, which is consistent with our cancer patient population. On the right side, you can see that the male and female proportion was equal. And on the right lower side, you can see that a majority of the patients were, white. And then there were, equal number of patients, roughly equal number of patients belonging to the Black and the Hispanic community. So this is the geographic distribution of patients that were included in the study. As you can see, the majority of or a large proportion of patients were in the Northeast. About 37% of the patients. This is corresponding to the initial wave of COVID-19, which was much more widespread in the Northeast, whereas Midwest accounted for about 28% of patients. We did have a couple sites from Canada and Spain, which contributed to a small number. Some other baseline characteristics that were included in this study was ECOG performance status. On the left upper corner is ECOG performance status. So this is basically patients with a 0 ECOG performance status are the ones who are pretty fit, who are doing well otherwise, able to take care of themselves. Whereas, the higher number you go, these patients are the ones who are weaker, who need help with performing their daily activities. You can see that a large proportion of patients had the better ECOG performance status, and some patients did have worse performance status, which is 2+. On the right upper side, you can see what is the cancer status of these patients, meaning are they in remission? Are they actively progressing? Are they responding to treatment? And you can see that majority of the patients were in remission. There were a number of patients, about 400 of them, who were active cancer and progressing, and there were about 1,000 patients who had stable disease. And if you look at the type of malignancies, 79% of patients had solid tumors, meaning tumors of the breast, lung, those kind of malignancies, whereas about 20% of patients had hematologic malignancies, meaning patients who had lymphomas or leukemias. And on the right lower corner here, you can see what is the percent of patients with different cancer types. And in this study, you can see the breast cancer patients, or the highest proportion, were about 20% of patients, or 19% of the patients had breast cancer, followed by prostate, lymphoma, lung cancers, and GI cancers. This is roughly the distribution that we would see in the community also. So this is a table looking at the rates of complications in these patients with cancer and COVID-19. So try to just focus on the rightmost corner here. So the rate of death at 30 days was about 14% in all of these patients. So now if you compare it to the general population, meaning patients who don't have COVID-19, their death rate is around 1 to 2%. So we see clearly that patients with cancer have a higher rate of death, almost 7 times as of the general population. And you can see that about 58% of them required hospitalization, 40% of them required oxygen, and about 17% of them required ICU admission. These are pretty stark numbers compared to the general population. So if we look at the 30-day mortality for select subgroups of patients, you can see in this table that overall, if you look at the global statistics in April 2021, the death rate in the overall general population was about 2%. Whereas for our cohort, the CCC19, it was about 14%. If you looked at the death rate in June 2020, which was a year prior to that, it was much higher. Now that suggests that, how our treatments have improved from 2020 to 2021, translating into an improvement in overall survival in these patients. Some of the other subgroups which showed a higher mortality include male sex. So if you're a male, the chance of dying was about 17%. If you had cancer that was progressing, 26%. Similarly, if you were more than 75 years and required mechanical intubation, meaning were in the ICU and required an artificial ventilation, the mortality was close to 70%. This is a table that highlights how the mortality changed over time in our cohort. Now, if you look at in the first phase of the pandemic, the first 4 months, the mortality was about 20%. And as and when we got better with treatment, the mortality reduced to 7% between September to November 2020. So if you were in the early phase of the pandemic, unfortunately, the chance of dying was higher. And as and when our treatments improved, the mortality decreased over time. This highlights the progress we've made in treatments of COVID-19 over time. This is a table showing what is the death rate or mortality in some of the select cancers. Overall, solid tumors, if you put everything together, the mortality was 13%, which is pretty close to the 14% seen in the overall cohort. However, what we interesting finding was that patients with hematologic malignancies, meaning leukemias and lymphomas, they had much higher mortality of 17%. And the most bottom one are lung cancer patients. They were found to have the highest risk amongst all cancers. So the mortality rate in lung cancer patients was about 26%. So what are those factors in patients with cancer and COVID-19 that might lead to increased severity of COVID-19 or death? Now, the ones that try to focus on the ones that have highlighted red. You can see that some of our underrepresented our minority groups, namely the non-Hispanic Blacks and the Hispanics, had about 38 to 46% higher chance of dying or having severe COVID-19 severity. Similarly, if you were obese or you were a smoker, you were a higher risk of severe COVID-19. And age and male sex. were also associated with the higher risk of COVID-19. Obviously, this may highlight some of the healthcare disparities related to lack of access, education, and socioeconomic status in these minority patients. This is data looking at these underserved or excluded populations and some of the regional differences that we've seen in 30-day mortality. Now, if you look at so the darker the colors, the higher the mortality. And in this chart, you can see that on the left side, patients who came from the Northeast had a higher mortality compared to Midwest or in the Western side. Again, that is reflecting the early stage of the pandemic where the Northeast was much more severely hit. And the table on the right side basically shows that the CCC19 registry has a lot of data in patients which are historically underserved, and we are planning to look at some of these in these specific subgroups of patients. So this table again is showing select cancer-specific factors associated with 30-day mortality. As I said before, having a hematologic malignancy increased your risk by about 44%. Similarly, if you had an active cancer that was progressing, your chance of dying was 2.88 times more, so almost 3 times more than someone who were not progressing. If you received recent cytotoxic chemotherapy, also these patients were at a higher risk of dying from COVID-19. If you compared, all the subgroups, the ECOG performance status of 2, so these are patients who are much more weaker. These patients had the highest risk of death, nearly about 4.5 times chance of dying from COVID-19. I'll try to explain this table. So this is basically this cancer patients who are getting different cancer treatments and looking at the mortality in those patients who are receiving different types of cancer treatment. So on the left side, you can see this graph here. So each bar indicates what kind of treatment were they getting. And on the left side, you can see the percent 30-day mortality. So you can see in the left side that patients who receive chemotherapy and immunotherapy, so the chemo-IO group, had the highest mortality for about 30%. And some of the other groups that had higher mortality included patients who received just chemotherapy or chemotherapy with radiation or targeted therapy. On the right side, what you see is the risk of dying from COVID-19 if you received that specific treatment in those time intervals. So for instance, now the table on the right side, you see patients who received chemo-IO. IO is immunotherapy. So this combination, patients who received this combination had almost a 2 times risk of dying from COVID-19 if they got the COVID-19 while they were getting treatment. Similarly, if you received targeted therapy, the risk of dying was almost 2 times if they received in the last 3 months. The right lower table is looking at specific types of targeted therapies, looking at anti-CD20. This is basically a targeted therapy mostly received by patients who have hematologic malignancies, things like lymphoma. They get a lot of this anti-CD20 treatment. The mortality in these patients was close to 50%. Similarly, patients who got a VEGF inhibitor, this is a type of chemotherapy that's given for patients with several cancers, lung cancer or brain cancer. Again, the mortality in those patients were about 40%. This data is from one of the papers where we showed that cancer patients with COVID-19, if they received hydroxychloroquine, Now, remember that hydroxychloroquine was one of the medications that was in the initial stages of the pandemic without any data, was pitted to improve survival in these patients. Some of the groups kind of spread disinformation or misinformation regarding the hydroxychloroquine until we had good data to show that hydroxychloroquine did not do anything for COVID-19. So what we showed in this study was that cancer patients with COVID-19 who received hydroxychloroquine for treatment of COVID-19 had almost a 2 to 3 times increased risk of death compared to someone who did not receive it. Similarly, remdesivir, which was actually one of the first treatments that were to be approved for COVID-19, in our study was associated with survival benefit and showed almost a 60% reduction in the risk of death. So mind you, this was in the early stage of the pandemic where we had little data about effectiveness of these treatments. Now, this is a slightly complicated figure, but I'll do my best to explain this. On the left side here are different types of chemotherapies that are given for different cancers. And the bar's height indicates the total number of exposure for that specific drug. On the upper corner here, you can see that there are a number of bars. So those number of bars basically represent the number of patients that got that specific drug or a combination of drugs. So for some cancers, you treat them with one drug, while other cancers, you treat them with a combination of drugs. So what these lines which are joining in one column represent that these two drugs are given together. So what we see in this chart is that patients who received R-CHOP, right here, these are the patients who had the highest mortality here. So you can look at here, so the mortality was more than 30%. So this were the group of patients who had the highest mortality with COVID-19. And this is just highlighting the R-CHOP group. If you look at some other data, so what are the other combination of cancer chemotherapy treatments, which also has a high mortality? These are patients who got platinum and etoposide. So this is typically given for small cell lung cancer. Their mortality was 30%. Whereas R-CHOP that I previously mentioned, which is typically given for lymphomas, the mortality is 36%. Now, patients who got DNMT inhibitors, so these are a very small group of patients. These drugs are given typically for MDS or pre-leukemic conditions. Their risk was the highest overall at 50%. Now, this data is looking at the efficacy of COVID-19 vaccines in patients with cancer. Now, when the data for vaccines came out, typically all these cancer clinical trials exclude patients with previous history of cancers. And we saw that there was no data for the efficacy of vaccines until later, or 3 or 4 months from the initially published data. And what we saw was that patients with cancer showed a delayed or negligible seroconversion to vaccine. So what that means is patients with cancer, because of their lower immunity, they had a suboptimal response to vaccine, meaning they were not able to produce enough antibodies against the COVID-19. Also, patients with cancer who are infected with COVID-19 usually have much more prolonged virus shedding. So the virus stays in their body for a longer time because of the lower immune system. And we also noted that patients with cancer who received specific types of therapies, especially the anti-CD20 therapy, things like rituximab, which are typically given for lymphomas. Other therapies like CAR-T therapies, which are much more advanced therapies given for relapsed leukemias, and patients with stem cell transplant had the lowest rates of seroconversion following vaccination. Now, one of the first study to show the safety and efficacy of the vaccine, the Pfizer vaccine, was the SOAPS-2 study. The table is showing below that about 151 patients with cancer, about 95 of them had solid tumors, and 56 of them had hematologic cancers. And these were compared with patients who did not have any cancer, or 54 healthy controls. And what we see in this table is that at week 3, if you look at the response of the B cells, the B cells are the cells which make antibodies against the COVID-19, and T cells are the cells which actually have the potential to kill the virus. You can see the rates of response in healthy controls at 3 weeks were pretty high, about 94% and 82%. At week 5, so as time passes, that response decreases over time in the absence of a second dose. So a second dose is absolutely needed so that the response of both B cells and T cells is maintained. Now, if you look at the response in patients with solid tumor or hematologic malignancies, you can see across the board that patients with hematologic malignancies have a much more inferior both a B cell response and a T cell response to these vaccines, meaning that these patients still can develop breakthrough infection despite being vaccinated. And since then, there have been a number of studies that have published showed that the rate of seroconversion in patients with cancer varied anywhere from 20% to 90%. So this paper is showing the efficacy of or the effectiveness of COVID-19 boosters in patients with cancer. So let me just go through this with you. So on the left upper side, what this graph is showing is that the levels of antibody titers in patients who got 2 doses of vaccine, so this is post full vaccination, in 2 groups of patients. So the red ones are hematologic malignancies, and the blue ones are solid tumor malignancies. So you can see that over time, following vaccination, in most of these patients, the levels of antibody titers decrease over time. In the middle corner, you can see that if these patients receive the booster, how the booster increased those levels of antibodies following the booster. So you can see how this thing drops off, and then just pre-booster, and then post-booster, how in the majority of these patients, again, the levels go up, suggesting that booster is an effective way to keep up the immune status against the COVID-19. On the right side, on the right upper corner, you can see the effect in patients who had prior COVID or with no COVID. And what this graph shows is, irrespective of whether you had COVID or not in the past, if you received a booster, your levels of antibodies will go up. Meaning that it doesn't really matter if you had previous COVID, getting vaccination and booster, again, further increases your chances of having a good response to the vaccine and potentially preventing the COVID-19. In the lower graphs here, this is again looking at the same levels in patients who received anti-CD20. These are the treatments which actually deplete the B cells which form the antibodies, and you can see that patients who received recently, within the last 6 months, anti-CD20, the rise in titers were not very significant. Last slide here. the panel E showing the effect of the two different RNA vaccines, mRNA vaccines. So both the Pfizer and Moderna are equally effective with booster. Now, once that we've kind of gone over the effect of COVID-19 in patients with cancer, we've gone over the effect of the vaccines in patients with cancer. Now, this data is looking at how the cancer screening was affected during the pandemic of COVID-19. So you have 4 different graphs here looking at screening for common cancers like breast cancer, colon cancer, prostate cancer, and lung cancer. And just to give one example here, so if you look at the breast cancer screening, you can see that the orange graph is 2019, and the black line is 2018, and you see the blue line is 2020, and you can see as February and March approaches, the number of patients getting cancer screening declined very steeply. And then it took like 6 months to kind of go back to the pre-pandemic level. Similar findings or observations were made with other cancers as well, like colon cancer and prostate cancer and lung cancer as well. Apart from health impacts, patients with cancer and COVID-19 also have a lot of psychological impact. One study showed that the reason for psychological distress was the fear of COVID-19, the fear of cancer progressing, and disruption of the oncologic services during this pandemic, delays in cancer workup or treatment, and obviously the immunocompromised status were the most common causes of psychological distress. Also, feelings of isolation and loneliness that tremendously increased during this pandemic has led to increased levels of anxiety and depression amongst the patients. End-of-life care has become challenging in the face of the pandemic, especially in the acute care settings like hospitals. When I was rotating in the hospital, seeing patients who were admitted, especially in the ICU, it was very heartbreaking for some of these patients to say goodbye to their loved ones on an iPad. It was one of the most, I think, challenging times for me as someone who takes care of patients with cancer. We looked at all the negative impacts. The COVID-19 did also have some positive impact during these times. Prior to the pandemic, telehealth was not recognized as a viable option, meaning patients doing virtual visits on the phones or on the video visits. This was virtually non-existent prior to the pandemic. And we've seen that since the pandemic, the rise of the telehealth visits initially and then have kind of, now plateaued, which is great. I think it provides a flexible options for some of these patients who, don't have to necessarily be seen in person and can be managed on the phone or video visit. My hope is that the telehealth will continue to move forward as a viable option for some of these patients. The other interesting thing that was noted during this COVID-19 pandemic is that there was a sharp decline in incidence of other respiratory illnesses during the pandemic. And in one example here, you can see that in adults and children, the rates of influenza and RSV, which was about 11 to 13% during the 2019, decreased to almost 0% in 2020-2021. Now, this is possibly the impact of hygienic measures like masks, social distancing, and hand washing. Currently, we have several studies at the University of Minnesota looking at cancer and COVID-19 patients. CCC19, I'm the lead investigator here. We also have an NCI COVID study. Dr. Kratsky, who is also a lung cancer doctor, is leading this study. Now, this study is looking at a more longitudinal study, meaning follow-up over time to look at long-term effects, following COVID in patients with cancer. I also have a study open here, which is looking at the effectiveness of COVID-19 booster in patients with cancer. Here's my concluding slide. The pandemic is not over yet. As I showed in my earlier graph that, in Minnesota, we continue to have the surge of hospitalized patients. And this will continue to impact both healthcare workers and patients alike until we get through this. We still don't know or know very little of long-term health impacts of COVID-19 infection in survivors. Now there's a new entity called long COVID. This is basically is still under study, but not much more is known about this. But some of these patients who have recovered from COVID-19 have symptoms of long-term fatigue, decreased energy. They have cognitive impairments, meaning difficulty in thinking. And these are, despite being recovered from COVID-19. So this is something that's been actively being studied under research. I think the pandemic has certainly, brought, attention to some of the disparities that needs to be addressed across the healthcare system and COVID-19. I think maintaining effectiveness of vaccines against novel variants will be challenging. Patients with cancer will continue to be high risk for COVID-19. And our health systems, our providers and patients will need to continue to adapt and evolve if we have to get through this pandemic. We obviously need to develop tools to fight misinformation and disinformation regarding some of these concepts. These are my acknowledgements. I worked with one of the medical students, Grace Wilson, who has contributed to the cases in CCC 19. I had funding from University of Minnesota Rapid Response Grant and also Lung Cancer Ambition Award this year. I thank the patient and families for their involvement in research, mentors and colleagues in my division, and my family who supported me through all of this. Thank you.
All right, wow. Well, thank you so much, Dr. Kulkarni, for your wonderful and very informative presentation. So we do have a few questions that came in through the chat box, but if you have any questions, please feel free to send them through the chat box. So before we move on to our discussion and the Q&A portion of today's session, I just wanted to let everyone know that we will be sending out a survey that will be emailed to you following today's session. And so please don't forget to do that because you will be entered in to win a swag bag filled with Masonic Cancer Center goodies. So please do that. And then also, so we'll go ahead and get started. So Dr. Kulkarni, there was one question that came through earlier on in your discussion. When you were sharing the slide of the 30-day mortality amongst the cohort, a participant had asked about the 30-day death rate for women, because you mentioned it was 17% for men. So if you could please speak a little bit about that.
Yeah, so the risk of death was lower for women. It was in the range of 11 to 12%.
Perfect, thank you. All right, and then there was another question that came through asking, could you explain how ECOG is determined? They didn't quite catch what represented that.
Yeah, so basically whenever we see patients in the clinic, we always like to know how they're doing. Meaning, so ECOG performance status is a representation of how active they are. So if someone who is very active at baseline, they have the best ECOG performance status, meaning that, if ECOG is 0, they have, they are very active at baseline, they're able to do everything that they want. They can do some, activities, some activities that will not cause any exertion. And as you move from ECOG 0 to ECOG 4, 4 is the kind of the highest number you can get. So for instance, ECOG 3 and ECOG 4 are the patients who are mostly bedridden, who are in the bed most of the time, who need help with carrying out their daily activities.
Perfect, thank you. So I'll talk a little bit more about the e-gift card after we wrap up our Q&A session, so I won't forget about that question. And so Dr. Kulkarni, can you speak a little bit about just any advice that you can share to cancer survivors, parents of cancer survivors, or just any caregivers who are feeling anxious during these days with the uptake in COVID cases, the spread of the Omicron variant as we approach the holidays?
Yeah, that's a great question. So, like to point out that we still don't have a lot of information about this Omicron variant. There is a reason for concern, but there's no reason for panic. Mm-hmm. Meaning that if you're vaccinated, please get vaccinated. If you're not vaccinated, please get your booster if you haven't gotten the booster. Now, recently, there was some data out from Pfizer suggesting that if someone had a booster, they were able to fight. They will most likely be able to fight the Omicron variant. I think the message should be that everyone should get at least 3 doses of vaccination. I think that is the best way to prevent both severe COVID-19 and deaths. Now, coming to as the holiday approaches, I know that a lot of families are looking forward to holidays, spending time with their loved ones, and mostly here in Minnesota, this is all indoors, right? So that kind of brings in a risk that it's difficult to ignore. So what I've been telling all of my patients is, if you want to have like a big indoor party, I am suggesting obviously to admit only people who are fully vaccinated and potentially even got a booster. So those are the people who are less likely to transmit COVID, especially if you have conditions that will predispose you to higher risk. So things like cancer, especially the hematologic malignancies, leukemias, lymphomas, or a stem cell transplant. These are the highest risk group categories. So I would definitely advise these to these patients.
Thank you so much for that advice. And so let's see here. Okay, no other questions came through. So this is kind of a big one. And so feel free to just answer it as you can. But what changes in cancer care delivery, and you spoke a little bit about this, but what changes in cancer care delivery should remain after the pandemic, and to what degree will these changes reduce or potentially worsen disparities in cancer care access and outcomes?
Yeah, that's a good question. So I think my hope is that when I talk to my patients, some of them really were very glad to have the option of doing visits virtually. So things like phones and video visits have actually changed the healthcare during the pandemic significantly. So my hope is that this continues. Now, at the same time, I think we need to, as physicians and as providers, we need to, make sure that some of these things are kind of easy to navigate for patients. Because I've seen some patients who live, up north and who have difficulty in doing these visits virtually. For instance, it's challenging for them, because it's not simple enough for them to be able to do virtual visits. Sometimes we find it challenging. So I think we have to come up with solutions which can make this accessible to to anyone who does not need to have like an advanced knowledge of computers or things like that, or how to operate phones, to make it very easy for them. I think that's one aspect I hope will continue even beyond the pandemic. The other, I think the other takeaway is, how level efforts like the CCC-19 can change, some of the, can highlight some of these, healthcare disparities. So I think this has really highlighted, I think, some of the problems with healthcare access. I think we have to try to find out what are the barriers for healthcare in some of these patients, trying to make healthcare more affordable, engaging the community in combating, misinformation and disinformation. I think that is a key in a lot of aspects. And I think also from the policy making perspective, increased spending on things like, easy access for testing, right? We still don't, what I'm hoping is that, making, home testing, something like, home testing. So for instance, one example I can give is if you want to have a function, so you can have this in-home test ordered and then let only people who have a negative, instant test. So that way you can enjoy holidays safely. So these are the things that I would like to see continue through this pandemic and the holidays.
Perfect. Thank you so much. So I had one question come to me directly, but are you seeing patients with later stage diagnosis due to lack of screening and early detection?
Yeah. So certainly yes. So I am seeing some people who had either missed their screening appointment for COVID or for whatever reason. I have seen some uptick in patients who are diagnosed in rather later stage. But I think it's still kind of early to see that effect, especially in some other cancers. I feel that definitely the impact of COVID-19 will continue to show in the years to come, because there will be some lag in seeing some of those adverse outcomes.
So another question came through. So given the world that we live in, given the world we are living in the US, you mentioned we need to reduce misinformation and disinformation. It appears to, at least in part, be a political issue. Do you have any suggestions to just get through to people and to combat misinformation?
Yeah, that's a great question. And I think it is sad to see that issue like COVID-19 being made into more of a political issue than a healthcare issue. I think that, and some of it was because of the problem with the leadership in this country. I think because that has changed, hopefully most of it will change. I think it is also the responsibility of some of these social media platforms to be able to identify these people who are spreading this misinformation and try to cut it at the root, instead of trying to do damage control. And then I think lastly, as healthcare providers, I think it is our job to educate patients on what are the myths of COVID-19 and what are the things to do's and not to do's in this pandemic.
No, definitely. And so let me see here. All right. So one question just before we wrap things up. What is the one and just the biggest takeaway message that from your presentation that you want our viewers to know today?
Yeah. Patients with cancer are at a very high risk of getting severe COVID-19 and death. So if you are a patient with cancer, please get vaccinated. Please get a booster. And I would also urge all the close contacts and the family members also to get fully vaccinated and get a booster. I think that's the best way out of this pandemic.
Well, Dr. Kulkarni, thank you so much for joining us today and for just taking the time out of your really busy day. I mean, he's a physician, scientist after all, so we really appreciate you taking the time to just have a really impactful conversation with us. And so before we kind of run out of time here, just have a few things that I want to address that came in through the chat as well. But so again, you will receive an email shortly after today's session with a link to complete our survey. And so by you completing it, it will help us to continuously improve and also kind of help us plan the future fireside chats and kind of what topics, cancer and health related topics you want to see. And so we had a few questions about the $5 gift cards. So we will be emailing the $5 e-gift cards to all attendees in the next few days, but there is something that I do have to say, unfortunately, just due to some financial, so tax and financial aid regulations, we cannot send them out to University of Minnesota students, faculty, and staff. So everyone else, community members and external organizations, we will be sending out your e-gift card. So sorry for that. And so again, thank you so much everyone for joining us today. Keep an eye out for any future announcements that you see from the Office of Community Outreach and Engagement, because we have a lot in store for you in 2022. So happy holidays, everyone, and wishing you all an amazing rest of your day. Thank you so much, Dr. Kulkarni. Bye now, everyone.
Bye.
Oh, sorry, and one thing that I forgot to mention. In our follow-up email, Dr. Kulkarni's presentation will be linked as well. So you'll have access to that, and then the link for our YouTube so you can go back and view Dr. Kulkarni's presentation. Thank you, everyone. Bye now.